Our next speaker is Janet Wilson. I could try really hard, but I don't think I'd actually be able to succeed in embarrassing her. So I'll tell you that she is one of our pediatric nurse practitioners. She's also an advanced practice nurse manager here at UT Health Austin Pediatric Neurosciences at Dell Children's Medical Center. Got it. So she got her undergraduate nursing degree at Michigan State University and then got her MSN here at UT. And has been here for, I don't know how long, but several years, a long time, building the keto program. She learned keto from one of the world experts in keto, so Eric Kossoff at Johns Hopkins. And we have one of the largest keto clinics, not just in the state of Texas, but in the country. And we couldn't do it without her and our awesome team of dietitians. So she's going to talk about keto.
Thanks, Dan. So ketogenic therapy, what should you know? So as Dan mentioned, we have a pretty large ketogenic diet program. We've treated almost 600 patients in the last 12 years. So there's a strong chance that you've probably seen one of these patients in your clinics, or if not, you will soon. So what do you need to know? I think you need to know what is ketogenic therapy, does it work, who can it help, and is it healthy? So what is ketogenic therapy? So we consider a ketogenic diet if it makes your body produce ketones. If the diet is high enough in fat that you start producing ketones by burning that fat. So we have lots of different types of ketogenic diets. The most traditional one is our classic ketogenic diet, and that we talk about in ratios, and that would be a 4-to-1 ratio, with 4 being the fat and 1 being the protein and carbohydrates combined. Sometimes that ratio is limited to meet the patient's protein needs or if they have low caloric intake. And so that's where the modified keto came into play. And so that would be more of, if it's less than a 4-to-1 ratio, we consider it a modified keto diet. With both the classic and modified ketogenic diet, we have very strict intake for these patients. The dietitians calculate all of their meals carefully, and the parents, if they're doing solid feedings, they have to measure it on a gram scale to maintain that ratio. So it's pretty labor intensive. The food's not very palatable because it's so high in fat. So fortunately, in 2002, Eric Kossoff developed the modified Atkins diet, and that allows us to have families just keep to a minimum carbohydrate intake in a day. And then encourage fats in the diet. And then we just have them track that. We have lots of phone apps that can track those carbohydrates for the families and keep within that limit. The hard part is most of our patients have a limit for carbohydrates of 10 to 20 grams a day. So still very restrictive in that carbohydrate amount. To give you an idea, an average slice of bread has 15 grams of carbs in it. So these patients, we eliminate all grains. Most of their carbohydrates come from the vegetables that they eat. So it can be hard to maintain as well. And then we also have a low glycemic index therapy, and this one we don't use as much, but sometimes we use this as a stepping stone to work to a more restrictive diet, or as a stepping off point if we're trying to get families to let go of their diet therapy. And so with that, we just give families a list of foods that are low in glycemic index and have them stick to those foods. Does it work? Well, of course it works. We wouldn't use it if it doesn't work. So the diet was actually developed in 1921. So we've been using the diet for over 100 years now to treat epilepsy. But we did not have our first multi-center study until 1998. But this included 7 centers, including the University of Texas Medical School at Houston, and it created a lot of other publications this year, including an editorial by our own Steve Roach. And what that multi-center study showed is that at 3 months of classic ketogenic therapy, so that 4-to-1 ratio, that pretty intensive therapy, about 54% of patients had greater than 50% reduction of seizures, and 25% had greater than 90% reduction of seizures, and 12% of patients were seizure-free. And we typically use a ketogenic diet in some of our most refractory patients, so this is a really remarkable benefit. And and you can see here that benefit maintained for the most part over time as well. Well, what about our other types of diets? How do they compare? And so in 2019, we had a meta-analysis that was published with over 70 studies, and it compared the classic ketogenic diet to the modified Atkins diet. And you can see here, it's pretty comparable. So why make a child who eats by mouth eat nasty foods and the family measure everything on a gram scale? So we don't. So most of our patients who eat by mouth, we start on a modified Atkins diet. So who can it help? There has been no type of epilepsy that has shown to not be effective against the ketogenic diet. But we do have some information on who are our better responders to ketogenic therapy. We do have metabolic disorders like GLUT1 deficiency syndrome, where the ketogenic diet is their primary treatment, but then also other epilepsy conditions like infantile spasms, Dose syndrome, which I refuse to call Dose. It's spelled goose, like goose, so it should be Dose syndrome. Will typically have about 79% reduction of seizures. We also have been using it a lot more recently for some of our super refractory status patients. And of course, it's easier in our patients who are formula fed, in both children and adults. And we do have multiple pre-mixed formulas. They are looking at the diet for expanded use in a lot of different areas. There's still some limited research for these things. It's not showing to be as promising as how effective it is for epilepsy, but those areas are also being looked at. Is it healthy? Well, it can be, but only if it's closely monitored. So we monitor our patients closely with follow-up labs. We typically will do this at least a couple times a year, and these are our routine follow-up labs. In addition to this, our dietitians carefully calculate the dietary needs of all of our patients and recommend supplements as appropriate to make sure they're getting all their nutritional needs. Our patients that are on the modified Atkins diets, because it's not as restrictive, we don't do as many follow-up labs. So these here in orange are the ones that we tend to focus on for our patients who are on a modified Atkins diet. And your population who might be doing a ketogenic therapy as a lifestyle therapy, their diet is more close to a modified Atkins diet, but they're usually only restricting to somewhere between like 30 and 50 grams of carbs a day. So we often get the question of what's normal when we see these blood results, like what's normal for a patient that's on a ketogenic therapy. So our patient's blood glucose range is a lot lower that we consider acceptable, so 55 to 75. Now we still get nervous if our patient is, hanging around 57, and we typically will make a calorie adjustment for that patient, but it's not quite as alarming as it would be for one of your other patients. Ketone levels, we have our patients measure ketones in their urine, and our goal is typically moderate to large for those urine ketones. And then how we measure ketones in the blood is by the beta-hydroxybutyric acid levels. These vary by patient, just kind of metabolic rate and diet ratio. It's common for us to see levels between 2 and 5 millimoles per liter, but they can range up to 8. We also get nervous if they're getting up to 8, and would make adjustments. Sometimes this is reported as milligrams per deciliter, and there's a conversion for this. But so if you see a patient's BHB come back as like 31, don't get alarmed. Look at the units. It's probably milligrams per deciliter. The other thing is the CO2 levels. Our patients can be a little bit more acidotic, but our goal is still for them to have CO2 levels above 20. So we do want to treat that if we're seeing them continually be acidotic. And then vitamin D, because our patients are on anti-seizure medicines, we typically make our goal optimal for vitamin D and have it above 40, as well as so many of our patients are non-ambulatory, so we want to maximize that bone health. Common side effects. By far the most common side effect we see with our patients on the diet is constipation. It just removes a lot of fiber from the diet, and a lot of our patients are non-ambulatory, so they're already struggling with constipation. We usually will treat those with Miralax, magnesium suppositories, enemas. Senna tablets are also safe. We work a lot with our patients on this. I swear I ask as many questions about poop as I do seizures for my keto patients. But these are some safe things for you guys to use as primary care providers as well. Gastric reflux, there is a little bit of an increase in gastric reflux with our patients. We can modify feedings. Reflux medicines are safe as well for these patients to use. One of the things is like Nexium, the powder packets are great for kids, but they're really high in carbohydrate. So we need to do a capsule form for those patients. Carnitine deficiency, our patients need to have a healthy carnitine level to be able to metabolize fat for energy. So we often will supplement with carnitine. And then renal stones. If we see that acidosis, we want to treat it. We also monitor for crystals in urine and increase fluid and add bicarb for that. High cholesterol and lipids. This is always one of the big questions is a diet that's high in fat going to lead to high cholesterol? Not always. We ask our families about family history. It's something we monitor for. We typically will try and do a pre-diet level to see kind of where they're at. And what the studies have shown for our diet patients that are on long-term therapy is that we will often see an increase in cholesterol that first 6 months on therapy, then it kind of levels out, and then it returns to normal within a year. If we're seeing high cholesterol, we typically can add carnitine to help with that. We can do omega-3s. We can modify some of those fats. And sometimes we kind of lower the diet ratio. We do not get our blood work as fasting typically. And that's just because our kids are so medically complex and we ask a lot from our families. And if we can let it slide, then we let it slide. I kind of have our own normal range of cholesterol, which is usually around, if it starts heading above 250 or trending at between 250 and 300, I'll ask the family to get the next one as a fasting level, just to make sure that fasting level is normal. Labs to consider during illness for our patients. A CBC, just because they're sick, because you're going to want one anyway. So not really anything diet specific for that. But a CMP or a BMP, because our kids, if they're sick, especially if they have GI illness and they're having any vomiting or diarrhea, they are more likely to go hypoglycemic. They're more likely to have some acidosis or an electrolyte imbalance during that time. So just kind of checking on those things so that they can be treated. Beta-hydroxybutyric acid, just to make sure that they're not having too high of ketone levels. And again, we see this more if they're dehydrated, especially if they're having a poor intake during illness. Again, the normal blood glucoses and kind of the normal BHB for that. Another thing to consider is checking an amylase and lipase level. Our kids do have an increased risk for pancreatitis, which is not something we had seen in our clinic until COVID. And so I'm suspecting there's a relationship there. Management of acute symptoms. Our patients are all given kind of like a troubleshooting sick day guideline, but often they forget that by the time their child gets their first illness once they've been on the diet. And what we ask our families to do is if we're wanting to give clear liquids for vomiting, we want them to do that as a half-strength Pedialyte. So diluting it 50-50 with water so that gives them a little bit less carbohydrates than what they would in the regular Pedialyte. Pedialyte does make a sugar-free formula, but that seems like a good idea, but we really want them to go ahead and get some additional glucose during that time. So we'd rather have them do the half-strength Pedialyte. Powerade Zero is actually also an appropriate option. And then we have them just replace it at the same volumes that they would give for their feedings. Hypoglycemia, our families are also taught to watch for symptoms of hypoglycemia. Or if their blood sugar is less than 40, then we have them treat with 15 milliliters of juice. It can be any fruit juice. And just if they're still symptomatic after an hour, they can repeat that. And then the same thing with hyperketosis. We just treat with a little bit more juice with 30 milliliters instead. And then repeat that more aggressively after 20 minutes if they're still symptomatic. Additional things for you guys to consider as primary care providers is we want medications to be in lowest carbohydrate form, and that often sends people into kind of a panic. The biggest rule of thumb is if you can crush the tablet, that's going to be your safest, best option for our families. There are some sugar-free liquids, but just because it says sugar-free doesn't mean it's carbohydrate-free because there's a lot of fillers and thickening agents that are used with those liquid medications. So if you send something to the pharmacy as a compounded medication, asking it to be sugar-free and carbohydrate-free. And then cold medications, we get the questions about what can I give my child when they have a cold. They do make some diabetic tussins. They're typically dosed for adults, but it's the same formulation, so you can just give them the appropriate dose. Robitussin makes one, Walgreens makes their own version, and things like that. Because we're going to probably need to crush the tablet to get it through a G-tube, we want them to avoid extended release tablets, which typically means generics are often some of the easier tablet forms to crush. Another good indicator is if they look for dye-free, because most of the time those coatings can have color to them, and so dye-free can give the family an indication that it's not likely going to have a coating that'll make it harder to crush. Steroids can decrease ketone production, which sometimes can increase seizures in our patients, but that's okay. Like, we know you have to use steroids on your patients to treat them otherwise. And so they might have a little bit more seizures, and it might take a couple days to get them back into ketosis, but that's okay. We'll get them back there. We want them to be healthy. The length of treatment, we typically ask our families to give it 3 to 4 months minimum to see if it's working for their seizures. And if they have a favorable response, we'll typically use a diet for about 2 to 3 years. Unfortunately, it's hard to get patients off of the diet once they've had that benefit for 2 to 3 years, even though we can often see that benefit continue. So a lot of our patients have been on the diet for 10 years or so, and we just continue to monitor them closely. And that's it. Thank you.
Mm-hmm. What percentage of your patients do have G-tubes?
I don't have that number. I do know that more, and I suspect it runs in parallel, most of our patients are still on a classic ketogenic diet therapy. So it's around 60%. So.
Janet, great talk. One question here. This may go beyond the time we have, but the question is, I'm sure I won't understand your explanation, but how does the ketogenic therapy work?
Yes. So the short answer is we have no idea. So we still really don't know. There is a lot of research that's being done in animals, and one of the thoughts is it's just the metabolic change in the body, and the other one is it has to do with the gut microbiome. They're kind of the two leading theories. Dr. Veda?
How challenging is it to start ketogenic diet and vegetarian?
I'm sorry. Dr. Veda asked about how challenging is it to start ketogenic therapy in vegetarian patients. And it is a little bit more challenging, but we have 3 amazing dietitians that are super creative, and we have done it successfully for many patients. So there is also a plant-based ketogenic formula now, which is new within the last couple of years. That will make that easier as well. But most of my modified Atkins diet patients stop being vegetarian because they really get really excited about bacon. So, yeah. Thank you.